Well, I think we could probably get started at this point. Thank you all so much for spending your Monday morning with us, the BC Support Unit Fraser Centre. We're very excited to present this research cafe to all of you today, and even more excited that so many of you were willing to join us. We have a slate of really interesting presentations this morning. So we might as well just get started. I'm going to hand things over to Magdalena Newman, our team's fearless leader, to sort of get things going. So Mag, over to you.
Thanks, Alia. And good morning, everyone. I hope I'm coming through loud and clear for you. I'm so happy to be able to welcome everyone this morning to our Researchers Cafe on the topic of building bridges, and which is being held because we're all joining from multiple areas in the Coast Salish lands, unceded and traditional. And I myself am very pleased to be and grateful to be coming to you from Kitsilano, which is the traditional lands of the Musqueam, Squamish, and Tsleil-Waututh people. We have a wonderful lineup of speakers for you today. Before we launch into that, if you are hearing about patient-oriented research for the first time or meeting our team for the first time, which is the Fraser Centre of the BC Support Unit, please go to the bcsupportunit.ca website. Again, that's bcsupportunit.ca, or send us an email at frasercenter@bcsupportunit.ca. And I don't want to speak for too much because I do want to make sure we have time for all the wonderful talks we will be having today. And so I just want to thank my team, Alia, Rich, Bev, and Brittany for helping put this on. And I want to thank Elder Sheila Nyman, who will be giving us or welcoming everyone this morning with a traditional prayer and welcome. So without further ado, I want to hand the mute button over to her and just say that she is a Silth Métis knowledge keeper from the Okanagan Nation. She's joining us from Interior BC, and she plays a vital role as the elder on the team of Angela, Kaida, and Valerie, Nicholson, and others who you'll be hearing from today. So thank you and welcome, Elder Sheila.
Why, Lim, thank you for the welcome. My name is Sheila Nyman. I am Silth Métis from the Lower Similkameen in the Okanagan Valley. I want to acknowledge the ancestors of the territory that I'm on today, which is the Secwepemc people of the interior. I want to acknowledge the ancestors of all of the territories that each of us is sitting on. I want to acknowledge and welcome the ancestors that walk with each of us, because we all come from somewhere and we are all Indigenous from somewhere. I want to welcome all of these ancestors because the energy of the lands and within our DNA, within ourselves, travels with us. And those energies do communicate, they do connect. I want to welcome them and I want to thank them, hold my hands up that they have been with us and that they are here right now. I want to acknowledge all of the hearts that beat here. I want to hold my hands up in honor of your hearts that are open and given to the care and the well-being of humans. I want to hold my hands up to you for being the people that care about other people. It is no small task and takes very special people to be in the positions and be in the thought minds that you are in. I'm going to invite each one of us to take in a deep breath through our nose, right into our diaphragm and out with your mouth. I'm going to thank the maker of breath as we breathe in again through your nose, right through your feet, into the earth where you are sitting, and breathe out with your mouth. Grandmothers and grandfathers, spirits of the four directions, Lem Lem, thank you for being here with us today. Carry each one of us, help us keep our hearts and our minds open to the ideas that are presented. Help us to listen not only with our ears, but with our hearts to the messages, the information, and the knowledge that will be imparted. Help us to share. Help us to believe and to feel and make ourselves a part of the solution going forward. I want to ask for special prayers for all of our brothers and sisters who are suffering with violence, with addictions, and the painful parts of being human today. I want you to protect them. Thank you for being here with us, all my relations. Oh.
Thank you, Elder Sheila. And I just want to also encourage everyone in the chat to share which region, which traditional lens you are joining us from this morning. And without further ado, I'm going to turn it over to Alia to kick us off.
Thank you very much, Mag, and thank you, Elder Sheila, for starting us off so beautifully. I'd just like to go over the schedule for today really briefly, just so folks know when to expect a break. So we started with our wonderful welcome. We'll have our first presentation by Swapnil Shah, speaking on patient engagement with the South Asian community. We'll then hear from Angela Kaida and Valerie Nicholson on engaging peer Indigenous research associates. We'll then hear from Delia Cooper on patient partnership and research governance. We'll at that point take a quick break just to sort of stretch our bodies, get some water, and we'll come back and reconvene to hear Keetch speak about fostering collaborative research in the health. At that point, we'll do a shared Q&A period with 3 of our presentations. Angela and Valerie have to pop off right after their presentation, so we'll just save a couple minutes at the end of their talk for questions for their presentation. For everyone else, please save your questions for 10:45 if you can. We'll do another quick break just so I can sort out the breakout rooms on my end for Zoom, at which point you'll come back and you'll find yourself in a smaller breakout session facilitated by each of our presenters. And this is sort of an opportunity for smaller groups to sort of network and discuss a question that we've posed, as well as any other thoughts that you might have from today's session. And then we'll reconvene as a big group to wrap up and sort of close out the day. So that's it for the day. If you have any questions for me, please don't hesitate to pop a message into the chat. You can message me or anyone else from the Fraser Center on the chat, and we'll be sure to address any of your questions. And with that in mind, we wanted to sort of launch a poll. We want to know who's in the room with us today. So I'm going to launch that poll now, and if you could just take a moment to complete it, that would be wonderful. Great. So hopefully you're able to see the poll results on your screen. Let me know if you're not. But you'll see we have a wide variety of folks here with us today. Really curious if you marked off other and you wouldn't mind sharing your role in the chat box. That would be wonderful for us to just know a little bit more about who you are, what brought you here today. And with that in mind, let's just get started with our talks. So Swapnil Shah, you're on the line, I believe I saw you.
Yes.
Hi, Swapnil. So Swapnil, if you wanted to upload your slides, I can stop my screen sharing. And Swapnil is speaking to us about patient engagement with the South Asian community. Swapnil has been a patient partner with our team for a number of years and is a really fantastic patient partner. So over to you, Swapnil.
Hello, everyone. Just starting my slide share. Can you see the slides well?
Perfect.
Okay. Hello, everyone. Welcome. I'm going to start off by talking about patient engagement within the South Asian community. I'll start by talking about what patient-oriented research is and a little bit of my story and how I got involved with the Fraser Center. So first off, what is patient-oriented research? Patient-oriented research engages patients as partners. It focuses on patient-identified priorities to improve patient-centered outcomes. It is conducted by multidisciplinary teams in partnership with relevant stakeholders, and it aims to apply knowledge generated to improve the healthcare systems and practice. So you can see patient-oriented really has patient at the center of research. And this is something I didn't know before I got involved. And I got involved as a subject initially. And then once I got involved it was really great for me to know that there are people who do appreciate the role a patient plays in the research. Here's a slide on why researchers should try to engage patients. I'm a software engineer by profession, so that's where this slide actually comes from. But as you can see in the slide, a lot of people spent a lot of time and energy to design this walkway. But when the users actually wanted to start using it, they actually chose this path, which is actually the user experience. So if they did not involve the patients or the users of the system in the design, then the design actually falls apart. And that's what I was trying to show with this slide here is, you always need to involve patients or the users of the system in the decision that we are making. Patient engagement, sorry. So patient should be engaged in all phases of the research. As you can see here is patients should be involved in setting the priorities, formulating the questions of the study, identifying the study population, recruitment, choosing relevant outcomes, data analysis, interpretation of the findings, design implementation activities, translate documents into plain language, help develop practice guidelines and evaluation. So patients should actually be involved in all phases of the research. And that's what I'm trying to illustrate here is patients can help in all the phases of the research. Going back a little bit to my story, how I got involved. So I'll start right at the beginning. I was born in a small town in India. That's my parents and that's me in my first week. You will see through my story that it's very much a journey. So I was born in a small town in India. My father is a doctor. My mom is an educator. To find better opportunities, my parents moved to a bigger city. My dad moved to a big city called Bombay. Most people have heard Bombay in India, on the west coast of India. That's me at my first birthday. A very happy family, and just like a fun childhood. As I grew up a little bit, I moved to the United States for studies, and of course I moved first, and then I invited my parents over to visit. Again, my parents are great parents. I had a very loving family, and I moved to the United States, because that was also another step towards making our family more prosperous or making a better step for the family. My dad met the woman of her dreams when he came to the United States. Here's my brother. He met the woman of his dreams when he came to the United States. And then I met the woman of my dreams when I came to the United States. That's my wife, Urvi. We met about 10 years ago, and we fell in love and got married in America. She actually lived in Canada. And so after a few years, I moved to Canada. That's my first day in Canada, in Vancouver. And she was already living here. As you can see, a theme of journey continues. I've been here for 8 years now. My parents visited us, and that's the Canadian Rockies. And then here's my brother, my family at Victoria Butcher Gardens. A theme of, and if you can see, there's an extra member here, that's my brother's wife. So my brother is also a doctor, my brother's wife is also a doctor, my dad's a doctor. So a little bit of theme of medicine, and theme of moving, progress, travel. Coming to why I got involved with Sarc. Sarc is South Asian Health Research Collaborative. The vision of Sarc is building engagement within the South Asian community, building engagement health research in partnership with the South Asian community. The objectives are to build a community presence of Sarc by promoting engagement in health research, to identify the health research priorities of the South Asian community and build community relationships to address these research priorities, and to create a centralized registry of South Asians interested in research participation. So this is our team, or a few of us at the Sarc collaborative. The reason why Sarc was established, I want to go back a little bit on that. So South Asian community is the third largest community, this is the third largest South Asian population in Canada, in Fraser. Over 240,000 South Asian people. South Asian community makes up 16% of the population. Also, the South Asian community is 2 to 3 times more likely to develop heart disease, kidney disease, diabetes. And also South Asian seniors are less likely to report excellent or very good health and mental health compared to other seniors. So this was one of the reasons why we wanted to engage, or not me, I came in later, but why the collaborative wanted to engage the South Asian community. Finishing up what I talked about with my story. So I have exposure to healthcare as a C word, healthcare in India, America, and Canada, at home because of my family's medical background, and at work. I used to work for a company called Bchsn Healthcare, where we made software. I'm a software engineer by profession, but the business was, I was working for the nutrition department, where we made devices that would help people who could not digest their own food to get nutrition. So that's how I was involved with healthcare a little bit at my work. After I landed in Canada, after a few years, I was diagnosed with diabetes, and I was unable to find a good way to improve my diet to suit my health condition. By this, what I mean is there are a few classes that are given. I really appreciate the classes that were given here by the Fraser Healthcare. And the main message that comes in from there is, in order to live successfully with your diabetes condition, you have to increase the protein intake in your food. And because being from South Asian origin, and our diet is a little bit different, and our, just in general cultural practices, the messages that I got from there were not very easy for me to implement, just because of the way our diet is, how to increase protein, being a vegetarian and things like that. So that was one of the reasons that I was looking for something, or how I can improve myself, conditions for myself, and maybe for the bigger community. And also I had the curiosity to learn and take control of my own health. So that's my story on why I got involved. So I attended a health expo. So in order to improve my own health condition, I attended a health expo which was targeted for South Asians, and one of the people from BC Support Unit Fraser Center, they were standing there and asking for South Asian patients to sign up. That's where I met Rablin and Sonia. So Rablin was part of the Fraser Center, and Sonia was the research head of our Sarc community. So that's how I just signed up. Rablin likes to joke that there were only two names on the placard. One was mine and one was her mother-in-law. So the South Asian community doesn't really like getting involved in. Actually, healthcare or health condition is always considered to be a very negative thing, especially in our community. Anything to do with healthcare, people try to not talk about it because it brings negative connotations. Maybe that's the reason there were not too many people who signed up. But that's how I got involved. And as part of being a member of the Sarc community, I was obviously able to bring my patient experience. That's why I was there. But I'm also a software engineer by experience, by profession. And so I was able to bring some of that. Like as we went forward with the project, we actually developed surveys. And so I was able to help with a little bit of my software expertise there, and how to develop the survey and also how to promote the survey for the South Asian community to get involved and fill in the survey. There's a YouTube link here which I can share in the chat, but I got involved in a patient research video. Stuart McNeish, he makes some really good videos, and we made a video from the patient's perspective, from one patient or from few patients to other patients on why they should get involved in patient research. After being involved with Sarc, there were a few other opportunities that came my way. I participated in the certification. I participated in the certification in Foundations of Patient-Oriented Research, and then I was able to co-develop and co-facilitate a patient and stakeholder engagement workshop where I was able to teach those principles to upcoming researchers and other patients who would like to get involved in healthcare research. A couple of years after that, I was able to become a member of the Bchsn Patient Council. This is a representative group who advises the academic health science network on how to include patients in various research initiatives. I'm also a member now of the advisory council to the Bchsn board. Here we brainstorm how to make research more patient-oriented and increase the level of engagement. I just wanted to share what the level of engagement is here. If you look at the graphic down below, the first and the most basic one is informing the patient, which is provide patients with information. And that is not really patient-oriented research, but that's the first step. And then, the next step is consult, where you obtain the patient feedback. Next step is involve, which is to work with develop alternatives. Collaborate is to partner in each aspect of decision making, and empower is to decide. So, our goal is to keep making the research go towards the right, at least collaborate and above. And that's what we try to do at the council. And my role there is to share my patient lens and represent my geographic area, which is Fraser Center, where I come from. So this graphic of inform to empower is actually part of the IAP2 spectrum. And I was able to actually go to a conference at IAP2 and share my story with Rablin, who's pictured here with me, where we talked about the lessons learned and how to engage the South Asian communities, challenges and successes. As part of my journey, here's what I've learned is it's amazing to hear inspiring stories of other patient partners. I obviously first started or became part of it to improve my own condition or how to live better with my condition. But then when you get involved and hear other stories, it's just amazing. It's very inspiring. And also it's great to know that the healthcare system is willing to listen to the patient's point of view, and they are willing to incorporate our ideas into the system. One of the key quotes about patient-oriented or patient-centered care is nothing about me without me. So always include patient partners in all decisions that are going to impact us. Here's another quote that came from one of our patient council members. The power of one patient partner comes directly from the strength of many people, and it all flows through the organization that brings us all together. And so I'm really passionate about this. I've been involved for 3 to 4 years now, and I feel like this can really make a significant difference getting patients involved in healthcare research from the patient's point of view, and also for the health research or healthcare team to get patients involved in their research projects. I want to talk a little bit about specifically about the South Asian community and the challenges that we faced and how we tried to overcome them. I think all patients and South Asian community in particular, they would like to know answers, or the people who are approaching the community should have these answers ready so that people are feel more comfortable. So the first theme is meet them where they are at, and by that what we mean is what kind of health research knowledge does the person have, and how we can provide them some information about that and how they can feel more comfortable to join the project. Then what additional reading materials are needed. The researchers who've been doing research for a long time, they have a lot of knowledge or things that they take for granted, which a patient who is new might not have. So if you can provide some reading materials to them, they would feel more comfortable and more engaged in the project. Also have a point person on the team for patient partners. Sometimes these research projects, especially with COVID, obviously everybody's remote, but even during when we were able to meet in person, we would meet sometimes once a month or sometimes every 2 to 3 months. So we are not very familiar with the entire team. So if we could have one point person on the team for patient partners, like the Bchsn support unit Fraser Center played that role for me, that would really make the patient partners comfortable. The next thing is, how do they like to be communicated with? Some people like email, some people like phone calls. Nowadays, Zoom obviously is kind of required, whether you're comfortable with it or not. But it's very important to take that into account, how people like to be communicated with. And then what are the roles and responsibilities for all the team members? So sometimes when a patient partner joins the project, the rest of the team is already set up and they've been already working together with each other. So it's always helpful for the patient partners to know what role others are playing. And then meet people where they're safe in the communities. This was, as I explained during my journey, is, I would not have known about this research project happening unless when I went to the Health Expo and somebody from the project came there to recruit us. So you have to kind of, as a researcher, feel safe in the community. And also it was on a weekend, it was not during 9 to 5 in a particular office, because that's generally not where patient partners are going to meet you. I was employed full time, but I went to this thing on a weekend, and Rableen was there, holding a placard, and she was able to recruit me. So meet people where they feel safe in the community. And I think that's the end of my talk. If we have some time, then I can take some questions now, or we can have them later.
Thank you so much, Swapnil. It was so great that you were just able to lay out the foundations of patient engagement and patient-oriented research for all of us today, so we could be on the same page. I especially loved just the reflection on your own story. And I'm personally thinking a lot just around what you said around just meeting patients where they're at, and really recognizing that, as researchers and as support staff, we really should be putting in that extra effort to make sure that patient partners' needs are well considered and that they have everything they need to contribute. So thank you so much. I think we'll move on to the next presentation if that's all right. But if everyone could please hold on to your questions for our question and answer period, that would be amazing. And we'll continue this discussion. So thank you, Swapnil.
Thank you.
Swapnil, if you don't mind stopping your screen share for us. Perfect. Angela and Valerie, I'm wondering if you are both ready and ready for our next presentation. Perfect.
Yes.
Fantastic.
Yeah, I think so. Just managing a few things.
That's perfect.
Is Valerie?
Yep.
Valerie.
Oh, there. Hi, Val. Okay, great. So let me make this. And oh, great. I can see Elder Sheila too. A lot going on this small screen. Okay, wonderful. Well, thank you, Swapnil. That was an amazing presentation. I loved it. I loved the stories. I loved the photos. I loved the journey theme across the presentation. And thank you so much for setting us up so wonderfully for the talk that Valerie and I will be co-presenting today, called Our Responsibility is to Build the Bridge for Others to Travel, Engaging Peer Indigenous Research Associates in a Research Program. So welcome, good morning, everybody. My name is Angela Kaida. I'm a Canada Research Chair and Associate Prof in the Faculty of Health Sciences at Simon Fraser University. I have had the honor and privilege of working with Valerie, Nicholson, and Elder Sheila for many years now on a research program that's focused on, it's a community-based research program that's focused on supporting the health and well-being of women living with HIV across Canada, and including Indigenous women living with HIV. I myself practice allyship towards women living with HIV. And my interests as a researcher are about, I want to understand what compromises sexual and reproductive health outcomes and well-being for women living with HIV. What compromises those outcomes, what facilitates those outcomes, and what do we need to do to ensure that women living with HIV are experiencing the sexual and reproductive health outcomes, realities that they want as defined by them. And so that's how I kind of come to this research. And Val and I have been fortunate because we were invited by the BC Support Unit to deliver a presentation at their recent conference that focused, that really provided an overview of our research program called Chiwo's Paw, or the Canadian HIV Women's Sexual and Reproductive Health Cohort Study, focused on positive Aboriginal women. And so today, what we were hoping was, rather than kind of redo that presentation, is really to spend some time reflecting on this core theme of building bridges for this conference, and our experiences and reflections about doing that building bridges work in the context of peer Indigenous research associates. So at this point, I'll turn it over to Val to open us in a good way and to introduce herself. Just move this forward.
Good morning, Kwe, Ninda Luisi, Valerie. I am, Valerie is my GST name. The name given to me 4 days after my birth was the one the Eagles watch over. I was gifted the name Ninda Luisi, Nodi Wenda, which means wolf eyes from my Dene family, and Auntie from the Torres Strait Islanders. So I'm Mi'kmaq, Haida, Gypsy, and UK Islander descent. I'm a mother and a grandmother. I'm also living with HIV, and I work at the BC Centre for Excellence. I'm a peer navigator with AIDS Vancouver. I'm an artivist and a change warrior. I would like us to take a moment to remember all those that have gone on before us, and their voices will be forever heard. I would like to acknowledge that Angela and I are speaking from the unceded ancestral traditional territories, the lands and the waters of the Salish peoples. This is where we connect our bodies, our minds, our spirits, and our hearts. And I honor the Musqueam, the Tsleil-Waututh, and the Squamish.
Okay, so in preparing for this presentation today, we took some time to reflect on our own journey to research, the research that the support unit calls patient-oriented research. We call community-based research, and that language matters to us in this work. But we're hoping that we can do this type of back and forth between Val and I. And Val, I'm gonna ask you this first question about what your journey has been into research.
Thank you, Angela. It's a short but a long journey, I guess. To give a little bit of background about myself, about 15 years ago, maybe even less, I was homeless. I was living in the downtown east side. I was using drugs to the best of my ability. and living in SROs. And I heard the drum, and it brought me back to myself. Although I was still in my addiction, I was starting to look after my health, and I went to a conference, and I sort of got in between two people talking, and they were saying, we need somebody in the downtown east side that we can trust that might be able to do some research. And this was going to be the first across Canada, I call Turtle Island, where peers were going to be able to be working in research. And it was the food security study for people living with HIV. And somebody said, well, somebody you can trust is sitting right beside you. And that was my first invitation into research. It was the first time that community for peers to be actually involved. And they showed us this survey, and I just said, no, I can't take this to community. There is no way. I live in community. I stay in community. They're going to ask me. There's nothing about next steps about what you're going to do with this research. And they were using words like abuse. How often do you abuse drugs? How often do you abuse alcohol? I say, why are you putting labels on us? They were using words like mother to child transmission. I go, that's so blaming. I can't do this research. So they actually listened, and they changed their words, and they understood that I live in community, and that, you know, I would have to face my peers every day. And I want the best and most safer survey, and that doesn't activate emotions. And so that's how I got involved, because I took a stand to what was actually being done. And in the downtown east side, we used to call the surveys drive-bys, because they would come in because they have a great resource of all these different peoples, and they would never come back. And I wanted to make sure that we had that responsibility. Thank you, Angela.
Thanks, Val. And so I
have a question for you. How did you get into research?
So, I mean, I have, like many people perhaps on this call, I have a pretty traditional pathway to research. I went to graduate school. I'm very committed to women's health, and I saw research as a pathway of being able to contribute to do something to improve women's health. And so, but in my work here in BC, as I started engaging in community-based research with Val and others, really sort of the foundation of my research training got a bit rocked. As Val is saying, you know, we had these surveys, and we were talking to women about them, and they were telling us, you know, nobody is going to give you the right responses to this. They understand what you want out of this survey, and they're going to give you that. And in our training, we call that social desirability bias. But when we're in community, that's not told to you as kindly as that. And so when we started this work, it became really clear that in order to address some of the really structural barriers that were, you know, keeping Indigenous women or other women living with HIV from participating in the research process had implications for whether or not the services that were being designed, the programs that were available, would meet their needs. And so that fundamentally started to change how I thought about community-based research or patient-oriented research. It's really about transformation. It's about changing fundamentally the structures of how we conduct research, whose voices matter, whose experiences need to be part of these discussions, and where is this bridge going to, you know, to keep this theme of building bridges. We don't want to build a bridge to nowhere. We want to build a bridge to somewhere, and we engage in the CBR approach in order to do that. And I think for me, I'll just reflect a bit as an allied researcher working with and learning from Indigenous women living with HIV, from our Indigenous community partner organizations, from the rich oral and written history and literature on Indigenous health, and really finding a place where, you know, to committing to a path of reconciliation. And I really mean that not as some sort of grand statement or grand gesture, but really one of like deep respect and humility and reflection. Because I think when we do our acknowledgements of being grateful and being privileged to live and play and learn on the ancestral and traditional territories, I think wrapped within that acknowledgement, we have to, it has to exist with a reckoning of how we as researchers have benefited from the legacies of colonization, including how we've been privileged by our ways of knowing have been privileged over Indigenous ways of knowing. And that privilege extends to, I think, very consequential and at times very devastating consequences for Indigenous peoples writ large in society, but also within our sphere and influence of the research practice. And so I just am very grateful to the learnings that I have been so lucky to develop over time. If you want to work in a space that requires transformation, you need to work and learn differently with the communities that you're seeking to benefit, I guess, and learning of their experiences and recognizing and valuing their expertise. So that's been a bit of my journey, but I'm going to move us, Val, to our second question, where we've spent some time, learning. Sorry, I don't know why this is going ahead, but we've spent some time thinking and talking about, okay, what do participants get out of being a part of community-based research or patient-oriented research? But we also wanted to spend some time thinking about what we are learning from participants ourselves. So Val, can I ask you that question in your experience?
Good question, and I've forgotten my answer. No. Good morning, Monday. So I think I'll use words from my grandfather, that as learners we are teachers, and as teachers we are learners. And we have to keep that circle going. And I think I'm going to reflect back to the Chivo's Paw research that we did, and to look at this beautiful picture where we did our research. Our participants, we came to this land to do the work that we did, and to learn in a way that by listening to the community, what they needed, what they wanted, and how they wanted to do it, and to be a partner right from the beginning. So by listening to community and seeing that gap or hearing that gap and saying, why is there nothing doing, a subject maybe that we're not looking at or doing something about. So by really taking that and taking them to where they needed to be or where they wanted to be, I think it's a full circle. And to acknowledge, and in other words, my grandfather, is new knowledge is old knowledge to new peoples. And I think in our research where we did it in this circle, where I know in a lot of research, you have somebody that designs the research and they're way up here behind that gilded desk in that beautiful office. And, they put those surveys out to community for what they think they need. Where we did it, where we know what the participants wanted. And we worked together in that circle, that no one was above or no one was behind or below. No one was standing behind you. You were all equals in this circle, and learning from each other and developing the research in that way, that it became such a gift. I believe it was a gift to me to listen. It was a gift to be leading together and building that bridge so others can walk beside us. And it became a connection, and knowing that our participants are in the next steps, taking that research out into community, that it just doesn't end when they finish talking to us. I hope that answers some of that question.
Well, yeah, and I think I'll reflect, sometimes the learning seems like, oh, the participants should be learning, but of course, as allied researchers, we learn a great deal as well. And as researchers, we commit, of course, to ethical principles and standards in order to protect dignity, rights, well-being of our research participants. And, as an example, a key message presented in Chapter 9 of the TCPS2 is that community engagement and trust building are integral to conducting ethical research involving Indigenous peoples and communities. And so I think as researchers, we are indebted to our Indigenous partners who've trusted us, who've worked with us, who've taught us, emphasized how to conduct research in a good way. And through, I think, my own learning I've come to view a commitment to high quality research practices as much more than just an ethical, a good for science, but really a marker of a commitment, of a partnership with our participants. And I really have come to learn this through a number of different lessons along the way, but one was really focused on the consent process. And I had learned from Elder Sheila and from Valerie and many other Indigenous women about, slow down the consent process that you embark on with your participants. And so we collectively, we designed a consenting process. So as our participants join, how do we discuss the process of informed consent, and how do we request voluntary informed consent? And our practice has completely changed. So now, especially when we're doing qualitative work where we're together, we take time in our research agenda to read the consent form together, to read it out loud, have peers read the language from the consent form and open that consent form up for discussion to the participants to say, do you understand what you've been asked to do here, or why, or what your rights are? And I think I'll just say for myself, the questions that the participant asked really opened up for me that really what we're engaging in when we're requesting consent from participants. And participants coming back to us as a team to say, I've never been asked, I've never been shown or taught what consent means, why I'm being asked for it, what my rights are as a participant. And we know that this is a community that's been probably very over-researched. So in some ways that learning of like the consent process has never been done in that way is, I think, a failure, honestly, on behalf of us as a research community, but is a really important learning that we've developed through engaging in research in this way. So I'll move us on, Val, if that's okay, to our next bridge, building our bridge, about transforming the journey of research. So when we do research in this way that's community-based, what is it that we're learning that's transforming the journey of research that we wouldn't know otherwise?
So I'd like to read this from one of our participants. Everything I'm passing on to you guys, I've learned along my journey. And when I look at this picture of these two beautiful cedar trees, I really look at two-eyed seeing, which is looking at everything with the one eye as the Indigenous lens and one eye in either Western or settler views. And when I look at the research journey that Angela and I have been on together, and I'm going to ask her this question, how was it for her? But I see how I have started in research from being a participant in a survey, then asking to be that peer researcher in asking that survey, to become developing surveys and research, and now writing papers. And I know Angela has come the other way. But when I see this, I see two of us standing very strong and taking our strengths and weaving them together and involving both our learnings and teachings and also our participants, their words and their words of wisdom and what the community needs. And it is our responsibility to really, I think what I'm saying is really listen to community and what community wants and their needs, and to move forward in our research in that way. So I've always been on the ground. I guess I've really been a thorn in a lot of people's sides in my research journey in transforming it. I see Angela laughing. But I'd really like to hear from Angela, and how was it for you coming from the academic world and coming into Indigenous research?
Well, thanks, Val. I like that analogy, thorn in the side. I have to say that's a bit true. That's definitely a bit true. And I mean, I think that the work that we're all trying to do is transformational, and transforming the journey of research is never going to come easy. Nobody is going to clear the path for you and lay out the carpet and walk here and it's all going to be smooth. Of course not. There are going to be thorns, and there's going to be stumbles, and there's going to be prickles and all of that stuff along the way. So you're a thorn in my side, a lot of people's side, and we're grateful for it. So I think about the question of transforming the journey of research about, to ask new research, we need new approaches to answer new research questions. And I see those two things as weaving very closely together. And I think as part of my process is we've all in the work of HIV and women, we've long seen some of the barriers that come up in terms of who's being left out of the response, who is not experiencing the positive health outcomes of HIV prevention, treatment, and care, and why is that? And we see the same patterns because we're asking the same questions. And I think my process of working in this model of engaging peer Indigenous research associates, including Val and others, has been a real rethinking of how we come to the process of research. So when I watched Valerie design the Chiwos PA study, which is the study that we mentioned earlier, focused on understanding how women living with HIV, Indigenous women living with HIV, understand and experience their health and healthcare through traditional ways of knowing. What I witnessed was a process of centering the woman in the research and committing to a trauma and violence aware care throughout research. A genuine love for the women who were going to be there and a genuine concern for their safety above and beyond any other questions. And then in the space of being in the research space with Valerie, with Debbie Cardinal, our other peer Indigenous research associate, with Elder Sheila, and the women who trusted us enough to come to our research, to be members of our research program, was an openness in discussion that I had not been privileged before to hear or understand previously. And so I think that transformation, how we do things will change where we end up, will change the bridge that we are able to build and cross to the other side. So just watching the time, Val, I want to make sure I ask this final question from our perspective about building bridges for the next generation of peer Indigenous research associates. And your thoughts about opportunities and challenges.
Again, I believe that is our responsibility. There isn't enough peer Indigenous research associates. I know the AHA Center and beautiful people at Women and Children's Hospital Oak Tree have started, I don't like to say training them, but engaging them into the research and bringing them into that research world. It is necessary. And I think one thing that, like I'm a storyteller. So when I was doing research with Chiwos, and I had to go to a community, using someone else's office, someone else's building. And I went in there, I was all set up, and the participant walked into the room, and she took her chair, which was sitting beside the desk beside me, and took it to the farthest corner of the room behind me, and she sat there. I always turn my phone off when I'm working, yet my phone went off. It rang as we're partway starting the survey. And she goes, "What is that music?" And I said, "It's the crow hop." She goes, "Are you Indigenous?" And I said, "Yes, I am." And that broke down so many barriers for her. She was from Saskatoon. She had so much stigma and discrimination against her. She was alone here in the Fraser Valley. But just knowing that music and hearing it, which she's going off right now, I apologize. It showed that connection, and that is what we really need. We need to build that trust. We need to build that trust in research, because I think, like Angela said, we tell you what you want to hear, but when we have Indigenous people actually doing this research and talking to other Indigenous people, we've already got that trust built. I have that trust built in community, where now we're getting answers that are truthful from the heart, they're from the spirit. And working together, and with my connection with Angela and our research coordinator, Becky, who are totally amazing and practice allyship every day, But when we went and did this research out on this land that you're looking at right now, and with Elder Sheila, it became much more than allyship. We became family. We became a tribe. That trust was built. And I think that is the biggest thing that we need, is to invite our peers to come into this research world. They're seeing what is the path that we're building, and they're going to come along with us. So we really have to engage our youth and our elders and all those in between to become a part of this beautiful research that we are creating. Thank you, Angela.
Thank you, Val. I think on that note, I don't think I can add anything more than what you've already said, except to say I agree. And I think on that note, I will on behalf of Val and I'll just thank the BC Support Unit for giving us this opportunity to reflect on our experiences, and really thank them for the leadership that they're bringing to BC around engaging in this form of research that I think is making a big difference. Speaking as a researcher, is making a big difference to the questions we ask and the questions that we can answer. Val and I, there's our contact information. And I think at this point, I'd like to thank and raise our hands up to our funders, CHR, the AHA Center, SFU, the BC Support Unit. We thank you so much for your support. And if there is a few minutes for a Q&A, we'd be happy to take any questions, either video or chat or whatever works for you.
Thank you so much, Angela and Valerie. I'm sure I'm speaking for everyone in the audience when I say that that was a fantastic dialogue. I learned so much from just watching the two of you kind of shoot back and forth with questions. And it was very powerful, so thank you. At this time, are there any questions from the audience? And if there are, please feel free to put them in the chat, or you can raise your hand, use one of the little Zoom reactions, and I'll call on you. Valerie, would you mind stopping the screen share, or sorry, Angela?
Yeah.
Thank you, just so I can see everyone. Shona had a question in the chat for Valerie. Valerie, did you get paid for your work as a research associate?
Yes, I did. And when we do the trainings for our peers, when we're doing that work, they even get paid for coming to do that, because their time is valuable. We also make sure that they are get a good meal also with that. But yes, I do get paid. At the very beginning of my research journey, no, I did not get paid. And I had to actually speak out at a World AIDS conference on stage and actually say, you know, I sit around the table with everyone else that's getting paid, yet I had to pay for the long distance calls. I had to pay for my own time. And one of our beautiful allies, Dr. Mona Lufti, actually got up crying and said, oh my gosh, I didn't realize that you weren't being paid. So it just took speaking out, but yes, I get paid. Thank you.
Thank you.
I'll just say thank you for asking that question, because compensation for peer research associates is a critical, absolutely fundamental issue. We have, I think, done a lot in our team to really challenge the systems at our own institutions for their, I think they've got systems that are really kind of compromising around how to acknowledge the expertise and compensate peers. And I think in SFU and the Faculty of Health Sciences, they have really come along with us around the need to do this at a sufficient rate of pay without delay. That's been a bit of a fight, right, Val? Without delay, and just acknowledging peers as experts. Such a critical question. Thank you.
Yes, it is. And we are still fighting that, as there are some universities that don't understand yet.
Thank you both. Lupin had a question in the chat. She's curious to know more about the project that you mentioned, I believe the Chios PA project. If you want to take a couple minutes to sort of give us an overview, that'd be great. But if you also have a link for more information, and I can send that around to the participants, that would be fantastic.
Well, great, Lupin. Thank you for that question. We did just give a talk at the BC Support Unit. So Alia, if that talk was recorded, maybe if you could put that link into the chat, that would be wonderful. Thank you for that. Val, do you want to give a bit of an overview of the project from your perspective?
Yes, I'll try and make it short because I know time is precious. So looking at women's, our traditional ways of knowing and knowing about some of our traditional medicines and how we can integrate it into our health. So listening to the women, listening to my ancestors, being guided along the way, and trying to use the health balance wheel. And we developed a water medicine wheel, which, because water is fluid, water has so many teachings. And so using water, we went through like earth medicines, we went through the bumps and falls in healthcare by using a waterfall. We used a reflection pool for all our supports, which we rode on canoes. So using water, because we are on around the Coast Salish Seas here and how important it is to these lands. So we just wanted to use water in our health. And we do have also the presentation on the Canadian Aboriginal AIDS Network's recording. So it has one of the presentations on our research has also been recorded there. Thank you for asking.
Thank you so much, Valerie and Angela. I think that could wrap up our short question and answer for now, if that's all right, just so we can move on to the next presentations. But just want to thank you both so much for your time, for being with us today. And we'll see you back in the breakout in a little bit as well.
Thank you.
Thank you.
All right, we've got a lot of interesting questions coming in the chat group, so I'm going to hold on to a lot of those questions for our big Q&A session in about 45 minutes. Next up, we have Delia Cooper here to speak with us around patient partnership in research governance. So Delia, take it away.
I'm trying to share my screen.
No problem.
It's not coming up, is it?
Not yet, but I can share your slides for you if you'd like.
Why isn't it coming up? My goodness. Now is it up?
No, I'm not seeing anything.
Oh,
We did practice this.
is
Oh.
that it now?
Yes, perfect.
It always is a trick here. Just a minute. Slideshow. From beginning. Okay, should be there now. Okay, good. Thanks very much, Alia. It's my great pleasure to be here today to share the Fraser Health Research Cafe Day with you all. Our topic today, building bridges in research, is very important because many of you are frontline healthcare workers, and you are the people who see the problems or needs of our healthcare system in a very personal way. Oh, good. Patient partners also usually have numerous different reasons for becoming volunteers in our healthcare system. Some have had excellent experiences in their life journey and want to give back. And some want to fix the system because of personal disappointment or in the care of themselves or a loved one. Some people say that everyone is a patient, but this is not true. Individuals with deep lived experience with a prolonged disease are better at representing the patient voice in various situations and can contribute more meaningfully. I knew at the age of 16 that I would volunteer with the Arthritis Society. Why? Because I received excellent treatment with a team approach at Bchsn, a research program developed by the Arthritis Society, Dr. Harold Robinson, and Mary Peck, which included a rheumatologist, physiotherapist, occupational therapist, education about the disease, state-of-the-art medications, and career counseling. I then became a founding member of the Tri-City Arthritis Community Group, also called Hang Tough, back in 1983. And after my career, I rejoined the group when I retired early. This is a picture of our current executive on the right-hand side. And the other part on the left is a picture of one of the Arthritis Society's fundraisers called the Big Swim, and we supported it in the Tri-Cities. An affiliation with a support group or community group gives a patient perspective on our healthcare system and the needs of patients, not just themselves. Because of my volunteer work with the Arthritis Society, I was asked to work as a patient partner on the BC framework for osteoporosis, osteoarthritis, and rheumatoid arthritis with the Ministry of Health. Following the work on the, Following work on the BC framework, I became involved with the research of the Canadian Arthritis Network, and that was a CIHR-funded Center of Excellence. The network included consumers, which are patients, in every aspect of research, whether it was as a partner or a funding reviewer, mentor for research trainees, or on their management committees and board of directors. I was the co-chair of the Consumer Advisory Council for 3 years, and I held many different roles during the 7 years I volunteered with them. We have to remember that historically, and his 2007 is not that long ago, researchers were expected to develop their proposals independently with little help from anyone other than a colleague. People described it as the ivory tower syndrome. The results were frequently not feasible or useful to the medical and patient community, and were often not shared widely with the public. The Canadian Arthritis Network was the first network to dramatically change the way health research is done. In SPORE, or patient-oriented research, patient partners are accepted and planned for and included at the outset of a project. Patient engagement is defined as meaningful and active collaboration in governance, priority setting, conducting research, and knowledge translation. My journey to becoming a board member on the BC Academic Health Science Network was lengthy. In 2010, the Patient Voices Network was created, and I was one of the first members to join it. I became involved with the research project called RACE, or Rapid Access to Consultative Expertise, as part of the Shared Care Initiative with the Ministry of Health. In this program, GPs were able to quickly contact specialists when they had a difficult problem. As a result of this work, I traveled to many different conferences, including the IHI, or Institute for Healthcare Improvement in Florida, as a panelist presenting the patient perspective and information on the Patient Voices Network. When I was interviewed for the board position for the BC Academic Health Science Network, I was warned that there would be a number of older gentlemen, some of whom might not appreciate my presence. Over the years, I encountered several situations with old school researchers who truly objected to any patient partner's presence in any decision-making or governance body. I discovered I needed broad shoulders and thick skin. It really makes a difference, though, when a chair or facilitator in a meeting makes an effort to include the patient voice. And it always helps to have two patient partner members on a board. Dr. Charles Jago has been most welcoming on the BC Academic Health Science Network board meetings, as have the other members. The BC AHSN is the financial overseer for SPORE, which is the funding agent for patient-oriented research across the province. Additionally, the BCAHN has created other facilitators for researchers, such as BC Ethics and BC Clinical Trials. As a board member, I have continued to have opportunities to attend conferences. However, I always write a very thorough report following each conference. The benefits of public engagement in research are listed here, but my favorite quote is by Dame Sally Davies, and it goes, "No matter how complicated the research or how brilliant the researcher, patients and the public always offer unique and valuable insights. Their advice when designing, implementing, evaluating research invariably makes studies more effective, more credible, and often more cost efficient as well." And she was the chief medical officer in Staley. It's important to be sensitive about problems you see in the healthcare system. At meetings or conferences, there are opportunities before and after sessions to talk to people who might be able to do something about a problem, or they may know who to talk to about a situation. I usually try and join a table where I don't know anyone, and I always keep my stories ready. For example, I once had a terrible problem with ambulance crews wearing strong aftershave into the scent-free emergency department, and I'm allergic to scent. And so recently I talked to someone from BC Ambulance Association and asked if there was a scent-free policy for ambulance attendants. Another time I was sitting with someone from the College of Physicians and Surgeons and was able to describe a situation where a young woman had a problem obtaining a GP. She had complex conditions and went to 17 interviews and had to drive over an hour from her home community before someone agreed to take her on as a patient. How we audit our GPs makes it difficult for some patients to find a GP. So in future, I'd like to see two patient partners on the College of Physicians and Surgeons board, as well as every other health authority board, so that the reality of patient policy decisions and their outcomes are considered from the patient perspective, as well as the healthcare perspective. It wasn't long before I realized that stories were not enough. We needed hard data as well. But asking the right question, are you there? Okay. But asking the right question is paramount. For example, following an emergency surgery, I noticed that I was the only female patient in the entire recovery room. I asked the nurse if this was normal, and she looked around and said, "Yes, this is what our surgical roster looks like most of the time." This happened a second time in a different hospital and in a different health authority, where all the recovering patients were men or surgical patients, but the females who were there were simply very ill. I began to suspect that women were not receiving some surgeries as frequently or expediently as men. Then after that, my friend said her relative, who lived in another health authority, was needing a knee replacement, and so was her husband. They were both farmers. Her husband received the knee replacement within 3 months, but after 18 months, she was still waiting. Many surgeons unconsciously prefer to work on men because they're generally easier to work on. Determining if women were sick and not having their problems addressed adequately would have to be done by retrieving data. So I carried my stories and told them to whomever I thought might be able to help. And just recently, I noticed that there was a surgeon who was much more cognizant of equality in care. He actually went around in his recovery room and counted and tallied the number of women and the number of men that he had worked on that day. Asking the right questions of people who may have some power to check out these kinds of things is very important. That's why I became involved with the TP, the Technology Enabled Patient Engagement Steering Committee in Fraser Health, and also the Ministry of Health Leadership Council for Digital Health. Stories are important, but policies and equity in healthcare must be based on data, not just suspicions. This is the Patient Voices Network, which Swapnil mentioned before. It's their logo, and it applies to research as well as healthcare improvement. In the future, every health research proposal will have at least 2 patient partners, even bench science research. This might be frightening for some scientists, but we do have an educated population in British Columbia, with 50% of the people having university degrees. In fact, I know of people who have gone to the genomics conference in California at their own expense because of their rare disease. Any patient who has had a chronic disease for 10 years has learned a lot about their disease, probably as much as their GP, and certainly knows what works and doesn't work for themselves. Bench scientists should be able to find a bench buddy who is interested in their research. Bench buddies spend about 30 minutes once a month with that bench researcher discussing the research. If they mesh well, the bench buddies provide the patient voice in future research projects for that researcher. Presently, researchers and healthcare professionals who are interested in doing some research are so fortunate because of all the facilitators to support it. In addition to the Patient Voices Network, which has been available since 2010, we now have REACH, R-E-A-C-H, a platform which helps you find patients who might be interested in your research. And as well as SPORE, the BC Academic Health Science Network has created other facilitators for research, such as the BC Ethics, where its creator, its director, Terry Fleming, has harmonized more than 14 health organizations in British Columbia in order to smooth the path for researchers to obtain ethics approval. Not only that, she has promised that the COVID-19 proposals will be expedited and reviewed within 5 days. The BC Clinical Trials Management System is also providing a one-stop shop platform for researchers. while we used to have 10 or 12 clinical trials ongoing in any year, we presently have nearly 200 trials ongoing, including provincial, national, and global research. The BC Academic Health Science Network has been involved with the Ministry of Health as well to ensure the investigative research data platform is available to researchers across the province. All of these entities are part of the BCAHSN, it's a mouthful, and available to research whether they are part of a health authority or an academic institute, and in some cases, whether they're doing patient-driven research as well. A few years ago, I visited Couture. We took a bus trip to the top of the cliff. The road was a single lane with 29 switchbacks, as you can see on the right-hand side. When you met a vehicle coming from the other direction, for example, these two buses, one of the buses I was on, one of you had to back up to the previous switchback, and it could be quite a distance. The road was so narrow that vehicles frequently fell in the ditch, or a wheel would fall off the side of the cliff. All of the drivers would hop out and help the driver in distress. I think the patient partner movement is similar to this. It is a very long and windy journey, and many people need to help out along the way. However, the view from the top is well worth the effort, just as fully integrated patient partners in research and our healthcare system will be a spectacular accomplishment too. Thanks very much.
Thank you so much, Delia. What a fantastic story and presentation. And I'm just really reflecting on the last little metaphor of the Serpentine Road and the hard and winding work it takes to get to somewhere beautiful. With that, let's all take about a 5-minute stretch break. I know I need to sort of get my blood flowing, and reconvene back here in 5 minutes. So I'll see everyone back here at 10:30. Okay, thank you all. Hi, everyone. Welcome back. Feel free to just settle back in. Kate and I are just sort of navigating the screen sharing.
Alia, what can you see right now?
I see your screens as sort of a PowerPoint.
Okay.
You click on the slideshow. Okay, so now I see your slides as sort of the presenter mode.
Right.
So I
Which?
current slides and your next slide.
So we don't want that.
No.
Now what do you see?
I see your slides. They are a little truncated. It's sort of cut in half. I'm not quite sure how to fix that solution.
Hey, I have a solution. How about I stop trying to share and you share for me?
I'll do that.
Okay. Delia got it totally sorted, but apparently I can't do it.
I'm just gonna upload it. Thanks everyone for your patience. And Kate, you can just let me know when you'd like me to hit next.
Sure.
All right, do folks see the slides on my screen? Perfect. All right, Kate, if you are ready, go ahead.
Take it away. Awesome. Okay, I have to say, that's a tough act to follow. Those were like 3 incredible presentations. So thank you, Swapnil, thank you, Angela and Val, and thank you, Delia. It did 2 things for me. Number 1, it made me just incredibly inspired again for why I'm in health research administration, and how much I want to fight for making health research better within the healthcare system. So thank you for that. Feeling totally inspired. So I am coming in here with a bit of a different angle for you guys today. So hi, I'm Keetch. I'm the director of the Department of Evaluation and Research Services within Fraser Health. So I guess I'm going to talk to you a bit today from the perspective of a decision maker. But ultimately, as you just heard me say, I'm a research enthusiast, and my goal in life is to make research better and to facilitate research happening within Fraser Health. So Alia asked me to talk about fostering collaborative research within the Health Authority. And so I'm happy to do that over the next 15 minutes or so. But I'm going to put a caveat on it that you all have probably heard of COVID by now. So my role and the beautiful team that I work with every day, we've been very COVID-19 focused in relation to the work we do around research administration. So as I go through this talk today, I'm going to be using our experience with how do you get COVID-19 research happening within a health authority. I'm using it as a case study, so please go with me on that journey. So Alia, next page or slide. So again, we've all heard of COVID. And it's sort of rock. You can put the Shah on the light there, Alia, go for it, thank you. So we've all heard of COVID, and it has incredibly impacted all of our lives in different ways, both personally and professionally. Within the healthcare system and within my role in research administration, one of the research administration within a health authority, one of the things that absolutely has shone a light on is some of the barriers and gaps and obstacles that we face in making research happen within the health authority. This might not come as a surprise, but when people think of health authorities, they think of acute care, hospitals, making people feel better when they have issues. They've broken their arm, they have a disease. They don't necessarily think research, but we absolutely, research is incredibly important within the health authority context, and has such potential because we deal with the people that could benefit from the results of research the most. So forever the optimist that I am, yes, there is the obstacles, but Alia, hit it one more time, the clicker. Thank you. The most beautiful thing that I've found, and that actually has come out of my experience in dealing with facilitating COVID research within the health authority, is there has been such an invested and renewed interest within research, and in particular, this increased collaboration, not only regionally within our health authority, but across the health authorities and provincially. And so I'm gonna sort of walk through that and my experience with that with you guys. Next slide, Alia, thank you so much. So this is just to set a bit of context. I'm not sure if anyone has seen this before, but this is publicly available. This is sort of the provincial COVID-19 dashboard. I put it up for the purpose today to just sort of highlight that within Fraser Health, we are obviously dealing with the most amount of cases of COVID-19. This has been the case since the beginning, and this is, I think this is Friday's total, so you can see we are in the thick of it. We have the large majority of cases, and why that's important to this conversation is, next slide, Alia. Thank you, is that a lot of people, both internally to Fraser Health, but also externally, have come knocking on Fraser Health's door to contribute to the knowledge, the COVID-19 knowledge through research studies. So this is just a snapshot of sort of the totals of research studies that have come to the Fraser Health Ethics Board. So walking you through this slide, you'll see there's a few columns. Harmonized means, and this is where Delia was talking about Research Ethics BC and having a harmonized process. So this is where when there's studies that are multi-jurisdictional or more than one institution is involved in it, it goes through the harmonized platform. And she's right, the reviews of these studies have been just super duper, should I use that technical term, fast. Within 1 or 2 days, these COVID studies get ethically approved. The other column is Fraser Health only, meaning it's led and is only happening within Fraser Health site, not another institution or jurisdiction. But what you can see is currently we have 30 COVID studies happening. Another subset that have been ethically approved but are still working through the operational approvals. And then some, as we progress down, some are going through the ethical approval right now. Some have been worked on but haven't been submitted, and then some have been terminated because people potentially pulled out. But what you're supposed to see out of here is a lot of people are coming and knocking on our door to do research. Next slide, Alia, thank you. So I want to talk about some of the successes that have happened around dealing with bringing COVID-19 research into the health authority. So, and how collaboration has played a piece in that. So next slide, Alia. Thank you so much. So one of the really cool things that has happened and is totally because of COVID-19, but is sort of a special circumstance because of being a part of the health authority, is there's been increased partnership and interest from several of the hospital foundations that are within Fraser Health. So specifically the Surrey Hospitals Foundation, as well as the Royal Columbian Hospital Foundation, have stepped up to support both funding for research studies, but also funding for research infrastructure to allow those studies to happen. And as well, the Michael Smith Foundation for Health Research, of course, they run competitions to try to support clinician researchers, but they've also stepped up to provide support for research infrastructure and personnel to make research happen within the health authority. And although absolutely Michael Smith and hospital foundations have been friends to Fraser Health and have supported research before, it is because of COVID, it has skyrocketed and there's even more interested. Everybody wants to contribute to the knowledge, to the treatments, to make this better for everybody. So that's been fantastic. Next slide, Alia. The other thing that's happened sort of from that provincial lens, and for me, I have to say this has been just extraordinary, is so these are all my wonderful counterparts from some of the what we call the emerging health authorities. So of course, Vancouver Coastal Health is fantastic and they do amazing research, but Fraser Health and Island and Interior, we all do sort of a similar amount of research and we have similar resourcing. And the collaboration and partnership that has come about with these three lovely ladies is fantastic. We all have our specific health authority context and story that we follow, and we have systems issues that we need to pay attention to, but being able to have a conversation with my counterparts across the health authorities and listening to some of the issues that they've been going through, but also some of the success stories they have, we've really been able to bring together and tackle some of the issues operationally or institutionally that have come about by having a we're in it together sort of mentality. So we talk almost daily. We have regular scheduled meetings, and I think it has been to the benefit of Fraser Health and COVID research in general for us to be talking and collaborating in a bigger way than had been done historically. Next slide, Alia. The other incredible and really cool thing that has happened, so bringing it into Fraser Health, is there is a renewed or a heightened research culture within the health authority that I pay tribute to COVID-19 for making that happen. So at the highest levels within the health authority, research has a seat at the table now. So to sort of explain how the pandemic response has been structured within the health authority, how we deal with that is, so there's a regional emergency operations center, and so that brings people from all parts of the organization that have a part or a piece to say within the COVID response. So that can be virtual health, that can be testing and assessment, that can be mental health, that can be workforce resilience and recovery, all the bits, HR, all the things that you need to think about in order to have do a good job of the pandemic response. Research and evaluation got invited to that table, and it has been fantastic because it allows A, for us to have a voice, but B, to truly understand the response and how research can help from a systems level. So what are the main issues that Fraser Health is dealing with, and how can research help that? So that has been really important and informative. And in fact, we then were allowed to step up a research and evaluation coordination center, which is the way that again, Fraser Health is structuring and doing things. And that brings all the right voices to the table. So if you're thinking about how do you do research, instead of just me sitting at my desk and having a couple conversations with a couple of the people on my team, we have people from all different sections of the health authority. So there's lots of stuff going on in long-term care. So we have the regional research lead for long-term care. There's drug trials going on within the health authority, but we need to understand what's the capacity and feasibility issues with pharmacy. So we have the executive director of pharmacy sitting at this table. We have physicians who are living both the clinical experience of treating people with COVID, but then also have a interest in research sitting at this table. And this is the model of the coordination center has been shown to be really effective within the health authority because it brings all the right people to the table. And so Bev Pomeroy, who of course is our patient engagement specialist within the Fraser Center, sits on this committee as well. And this was just stood up a few weeks ago, but we recognize the importance of the patient voice in that, and we want the patient voice to be heard. And I can tell you, because I do sit at the regional emergency operations center meetings, that the patient experience gets brought up every single meeting. So although as I'll talk about in a little bit, we're not quite there yet and there's more we could do, it's not being ignored, and there is recognition that the patient voice is incredibly important in this whole journey. Next slide, Alia. And then some other things that have worked, and there's increased coordination and collaboration provincially. Delia again mentioned some of these aspects, but Fraser Health is a part of some of these provincial coordination initiatives that are looking to make COVID-19 more research more feasible and coordinated, and having the right people at the table and not duplicating efforts. And so these are different groups that myself or some of my counterparts within the health authority sit on. And then of course the BC Academic Health Science Network, you're right, that is a mouthful, Delia, of course has its the Clinical Trials BC, Research Ethics BC, POP Data BC, and they're doing a tremendous amount of work to make COVID-19 research happen. Next slide, please. So lots of really good stuff has happened, but there is always opportunities for improvement. So let me talk through a bit of those. So Swapnil, I stole your slide, although admittedly it was already in my slide deck. So I love this visual as well. So some of the stories that my fellow speakers have talked to today is there absolutely is work being done to engage patients within the health systems research. But I'm going to totally just admit it. In the context of COVID-19, there's more work to be done. So COVID sort of hit cycle 1, and the patient voice sort of, at least from the experience within Fraser Health, sort of took a bit of a backseat. I'm happy to say that I think that is shifting now. So for example, I know more and more of the studies that are coming to our door actually are having patient partners as part of the research teams. And this is again in relation to the COVID-19 studies, but we're not there yet. So more work needs to be done, but then again, when I've heard these talks today, it totally inspires me to fight harder for this. I'm so fortunate and lucky to have the Fraser Center as part of my greater department, and they do fantastic work. And Fraser Health and the research that is done within the health authority and within the Fraser region is better because of them. But guys, we have more work to do. That's clear. Okay, let's keep it going. Next slide, Alia. And again, because the health authority, it's different from academic institutions where, people are paid to do research. That's not the case within the health authority. Often research is done at the side of clinician and frontline workers, off the side of their desks. So I'm going to continue to really push and work to grow and find the resources to meet the needs so that we can continue to grow and support and sustain research within the health authority. Next slide, Alia. And one avenue, again, it takes a village that we're actively exploring. We do already have partnerships with a number of the academic institutions, but we are actively looking to increase this. And I know the Fraser Center absolutely does a fantastic job with reaching out to our academic institutions around patient-oriented research and engaging and engaging, sorry, I lost my train of thought there. Engaging academics and other relevant members of the research team in patient-oriented research, but we are actively pursuing that even more because there's so many questions that need to be answered in relation to COVID-19, and so we welcome and are fostering specific partnerships and with researchers to support COVID research that can impact our patients and our families and clients within the Fraser Health region. Next slide. So one of the questions Alia proposed to me was like, well, how do you engage? How do you get your voice heard within the health authority? If you're interested in doing research within the health authority, how should you do that? So next slide. So one of the ways, again, because I'm coming at this from a research administration lens, is one of the best ways to get your voice heard and get some traction is to look at things from a systems level. So Fraser Health has, of course, we all have priorities, and Fraser Health has priorities each year that they look to achieve in areas that they really want to focus on, and so one of the ways that we're trying to approach our COVID-19 research is to tie them into to these health priorities as much as possible. So I think you can click a couple times, Ali. I think I have extra animations there. Yeah. So go back one more though. Sorry. Perfect. So just to highlight and to talk about this, so obviously strengthening the pandemic and preparedness and response is one of the priorities. So thus all the COVID-19 research that we're trying to do, but we're doing other things, and again, sort of reflecting on some of the topics that the fellow presenters talked about today. We're really trying to focus the research on these priorities. So I know that the Fraser Center just supported, for instance, some mental health, and we all know opioid use is a huge problem. So the Fraser Center just supported a local research team to look at the experiences of people accessing the opioid agonist treatment in a virtual fashion during COVID-19. So there's something that just blends a bunch of the priorities. So opioid response, mental health, virtual health, and COVID-19. So that's a fantastic example in a project, and it's patient oriented. They have patient partners on it. So just an example, that's how to engage, is to pick the topics that are really gonna have substantial impact within the health authority. Next slide, Alia. Another way to engage is to engage my beautiful team. So we exist, we are a full service operation we're a service department within the health authority, and we do end to end. If you have a research idea, you can contact us and we can see it through the whole research journey, from conception all the way to dissemination and knowledge transfer. So I highly suggest that whether you're internal to Fraser Health, whether you're an academic partner from outside of Fraser Health, whether you're a patient partner, if you have an idea, just come knock on our door. And the easiest way to do that, Alia, is if you hit the next slide. Awesome. What happened? There you go. Is to check out our website. So fraserhealth.ca/research, we have a contacts page there, and it has all of the contact information of all my wonderful team, and you could pretty much knock on anyone's door and they're going to respond positively to you, and if they're not the right person that you should be talking to, they'll get you to the right person. So there you go. That's what I wanted to say today. Again, a bit of a different angle, a different approach, but there it is. I'm happy to take questions.
Thank you so much, Kate. I think it was fantastic to sort of hear a different perspective, especially that sort of institutional administrative perspective. So thank you for sharing. and really great to hear more about health and the COVID-19 research response. At this time, we'll do a shared question and answer period for our three presenters who are on the line right now. So Swapnil, Delia, and Keetch. There were a few questions floating around, so I'll look back in that chat, but if anyone else has other questions, please feel free to just speak up or pop them into the chat. Swapnil, Gloria had a question in the chat asking around opportunities to sort of engage with the South Asian community for patient engagement. I'm wondering if you can speak to that at all.
Yeah, so I think Bev replied back to her, and then so I think Bev is the best person to contact regarding that. I am still part of Sarc, but right now it's undergoing a little bit of a leadership change. So I think Bev would be the best person to contact.
Thank you, Swapnil. Bev, not sure if you wanted to add anything around opportunities or the patients interested in the research group.
Yeah, sorry, my camera's not working very well. But yeah, anybody, I put my email in the chat box. So we have a really activated patient partners, patients interested in research team at Fraser Center. We're super fortunate. They've had a huge impact at a provincial level as well with the COVID research that's been going on, as well as in the Fraser Center. So I'm happy to talk to anybody, particularly patient partners who want to get engaged and be a little bit more active in your own region.
Thanks, Bev. Shah had a question around sort of engaging people in the community to do healthcare research who are not what we would consider as conventional patients, who haven't necessarily gone through the healthcare system, but who nonetheless may have lived experience and be able to speak to their perspective. So wondering if any of the presenters have any thoughts around the community engagement piece, and if not, if any of the Fraser Center staff want to speak to that.
I guess I can speak to that a little bit, Shona. Is there any money for patients who are wanting to design study? I know, Ali, you guys can probably speak more to the planning grants and stuff, but for patient engagement in Fraser Center, we do have a budget for patient engagement. So if you're wanting to get patients involved in your project, even just to start bringing them together in a conversation, then we have some resources to support that financially as well. Because as mentioned earlier, we do believe in having patient appreciation in the form of dollars or gift cards or what have you. So again, happy to support whenever and however you need it.
Thanks, Bev. And Shona, to your point around community engagement, we at the Fraser Center really define patient as anyone who has experience with that health issue or the health system. It's quite a broad definition, and it does include friends or families or informal caregivers as well. And I think it's really important to note that that definition is really quite broad, and that it is up to the research team to sort of redefine what patient might mean to them. We're quite cognizant that for a lot of people, patient isn't an appropriate term, and they might prefer community-based research, client-focused research. It really depends on the team and the situation, and it comes back to asking your partners first. If anyone else has any questions or thoughts, we can take them now. Otherwise, yeah, Delia, absolutely.
I can just clarify what I meant when I said that not all people are patients. Yes, I do agree that caregivers are definitely eligible. They definitely are patient partners if they want to be patient and family partners for patient-centered care. But what we really need when we have patient partners on a board is to ensure that the patients on that board don't have to wear two hats. For example, if they're the lawyer, or if they're the accountant, or if they're the chair They may be patients, but their focus is not on providing the patient voice. And so that's why I am speaking that we really need to have that voice with no other hat that has to be worn. Just thought I'd clarify that.
Thank you, Delia. That's really important for us all to remember, I think. So at this point, I'd like to take a second to get us all out into breakout rooms. That might take a couple minutes on my end to split everyone up. So please feel free to take a little bit of a quick break. And if you come back in about 3 to 5 minutes, hopefully you'll find yourself in a breakout session if I can get this tech right. If you have any questions for our presentation or for our presenters, please keep them floating. Be sure to pop them in the chat, and we'll see you all soon. Hi, folks. For those of you in the main group, I tried to assign you all to smaller groups. I'm not sure what's going on. Perhaps you're just needing to take a break, which is totally fine. Please shoot me a chat if you want to be assigned back into a breakout room, and I'll do my best to get you in there because I'm not sure what's happening.
we can bring all this back there.
Hello, everyone. Welcome back. Thank you all so much for sticking around with us and participating in the breakout sessions. I heard a lot of great conversation happening in those. I'm wondering if we could have our Fraser Center staff who are in those rooms to sort of just give a very quick one-liner, around some of the conversations that came up. Brittany, would you mind starting us off?
Sure. So we had a bit of a conversation, and we got kicked out right at the end when it was getting good, but just about how to connect virtually and how to keep those relationships up, and try to maintain that trust and presence with each other online and in this new way that we're interacting. And Becky offered some really great tips, such as sending something physical to actually feel like you're physically connecting, like a physical gift or medicines and things like that, which I thought was a really cool idea. And yeah, I don't know if Becky wants to add anything.
Yeah, just that it takes a lot of trial and error in figuring out and just working together as a team to decide what works well for us in connecting in this virtual environment, and recognizing that it takes a lot more time, but it's really important time to invest in building relationships and also providing the support needed for other people to connect into that virtual environment.
Thank you, Brittany and Becky. Bev, can I ask you to share a little bit around your breakout session?
I think a good part of our breakout session was around what Swapnil and Delia were talking about earlier, which is really meet patients where they're at. And during COVID times, quite often that is around technology and understanding the tools for engagement that patient partners may or may not have access to. And again, around hours. I mean, Swapnil works during the day, and so making sure having meetings and ask and clarify, what time works for patient partners. And then Delia did mention having more than one patient partners, which we're all a huge advocate of, to have a variety of voices in the room. And then we kind of ended and didn't answer the question really, but one of the questions that came up that maybe other people have some ideas around is, what if there's conflict between patient partners? Maybe there's conflict between the research team. How do we, one, mitigate conflict? And number two, how do we manage conflict when we're in patient-oriented research? Having patient partners, well, we're quite passionate about the things that we're interested in that are important to us. So again, how do we sort of mitigate that conflict and resolve it on the team? So super open to suggestions or ideas around that.
Thank you, Bev. And last but not least, Rich, if you could give us a very brief overview, that would be amazing.
Yeah, so, and Mag, feel free to augment anything that I miss. I think most of what we talked about ended up being Shona's difficulties, or she's new to the area, only been here a couple of years, and trying to set up a research program, but having to do it all on her own time without any support for getting patients on her team, or support for her else to free up sometimes. So she's, any time she has is all the hours are paid for by her workplace. And so if she wants to do research, and she has to do it on her own time, and where's the funding for that going to come from? And if she's already working a 60-hour week like a lot of professionals, then we got to find another 15 or so or 10 to put together the research project, and that's going to lead to stress and all that. So why isn't there funding to support some time for her position to do research? So she should be given 20% or 15% or whatever, some kind of part of her salary or her funding should be to support that so that can happen. And so that is but it ends up being a problem that not just Shona faces, but is in the research system and in the clinical and health research field in general. Because again, if you want some kind of decision maker on your team that's in the health system, well, they don't have time for you to do research. Again, they have to do it on their own time. So it's all these people who would like to participate, but in fact are inhibited economically or time pressures or whatever. So I think that's a big problem, that a gap that is definitely one that we need to start looking at and addressing.
Thank you, Rich. That's fantastic. So I'm very cognizant of time, and I do want to allow Elder Sheila a lot of, enough time to sort of close us out. Mag, I'm wondering if you have any last thoughts to sort of wrap up our session before handing it over to Elder Sheila.
I think I just have really just words of gratitude for everyone that was able to join us today, and all the wonderful speakers. Thank you to Swapnil and Delia and Valerie for sharing your personal stories and experience, and Kate and Angela as well to help us understand how can we start building those bridges. For Valerie and Angela, thank you so much for really showing the way forward for us, how we can engage with communities and partnering with them in research, and particularly Indigenous research communities. I think that there's a lot that we have to learn from the work that you're doing, and that we can apply to so many other things. And I want to thank you, Kate, for giving us a snapshot of what it's like inside the healthcare system, particularly during this time, both the challenges and the exciting things that are happening. Delia, thank you for sharing what the supports are that are in place for BC researchers, and how the many different ways the public can become engaged or in research. And Swapnil, again, thank you so much for showing us how we can engage with the South Asian community, and we're very wise thoughts around that. So I want to just conclude now by thanking Elder Sheila. Thank you for your, wise and insightful and grounding words today. I think it really set the tone for our discussion today. And I just want to hand the mute button over to you to kind of have the last word and close us out in a good way. Thank you so much, everyone.
Right. Just wanted to express the honor that I feel in participating with all of you, and just sitting in this virtual circle with you, sharing the wisdom and the knowledge and the questions and the pursuit of more knowledge. I'm going to invite each of us to breathe in the energy from the universe. Breathe in everything that you need. She has it. Breathe out through your mouth. I'm going to invite you to breathe in again the energy of the universe right down through your body, through your feet into the earth. She is our mother. Breathe out anything you don't need to take from this meeting. Anything that doesn't need to come with you into your day. Let it go out with that breath. I want to thank all of the ancestors present with us today. I want to honor each and every one of them for being with us today and for being with each of us as individuals always. I release them, and we all can release them and go forth into our day. Grandmothers and grandfathers and spirits of the four directions, protect us, protect our families, protect our human family right now globally as we confront this pandemic as a whole globe, as humanity. Help each one of us to bring our focus to what is important as human beings, what is really important. And I think if we all think about it, grandmothers and grandfathers and spirits of the four directions, we know what is important is love and compassion and care for humans, all my relations.
Thank you very much, Elder Sheila, for closing us off today. I'd just like to say one last note of gratitude to our presenters and to all of our audience members for your presence and engagement today. and for your continued support of the Fraser Center. We feel extremely blessed to be able to work with such incredible partners. So thank you all. I will be in touch with likely a very short evaluation form via email, if you don't mind completing that at some point this week. And likewise, if you have any questions, comments, concerns, or curious for any of our support, please feel free to get in touch with anyone from our team. We're always here to talk patient-oriented research.
And Alia, will we be sharing the link to the recording of the session?
Yes, I will be. I'd probably just have to clean it up a little bit, just to skip the beginning part, but I will be sharing that link shortly as well. And with that, thank you all so much. I'm very grateful to have spent my Monday morning with you. Hope that this was engaging for all of you and that you took away something from us today. And yes, looking forward to connecting with all of you again later.
Thank you, everyone.
Thank you.
Bye, everyone.
Thanks.
Thank you. Bye-bye. Thank you.
Bye, thank you.